assess or present certain risks in these patients, and then you can target, say, in cardiovascular preventive strategies. Then you look at in those with high risk, you look for cardiac out calcium so that they prevent cardiovascular disease. So, if you were to look at precision medicine, this is how one would look at it. It's basically tailored to disease prevention and actually management to a given patient, and it involves genes, environment, lifestyle, and then also the interplay with omics. Talks you've heard a lot about it over time in the past 2 days: proteomics, genomics, and metabolomics. So, if we were to look at this traditional way of doing this, all patients get the same treatment, and you have response, non-response, and then you have side effects. But if you were to go, see this in the future, hopefully, we have precision medicine. You can, through a combination of these various omics along with genetics, define the risk profile of the person, but also susceptible to your response to treatment. And then if someone is a high risk for certain outcomes, you can start off with a more aggressive form of treatments and then down titrate. And if you have someone who is at low risk, you kind of go with a step-up procedure. And then you can then optimize the outcomes in that you have response, response, and response. So this is theoretically at least the right strategy as we move forward, rather than just giving everyone the same treatment and then see some response, some does not respond, some who has side effects. The more robust data with regard to either polygenic or monogenic risk is in the field of liver disease, in the field of metabolic syndrome associated steatotic liver disease. So if you were to look at HSD 17B13 and look at the epidemiology of that, in patients with fatty liver disease, clearly there's certain regions of the world where HSD 17B13 is more prevalent as opposed to certain other parts of the world. This is liver-specific, a lipid droplet associated protein that has enzymatic pathways that involve inflammation as well as actually steatosis. And loss of function of this is protected against progression of steatohepatitis and from simple steatosis to fibrosis and cirrhosis HCC. There is, apart from these points that I made, there is now currently the use of SR